My name's Peter Hibbert, and I work at Macquarie University in Sydney. And I started life as a physiotherapist many moons ago. So worked as a physio for about 12 years. For about the last 20 years, I've been working in the area of patient safety and also the healthcare system delivering evidence-based care. So, and my more recent things is really related to when things go wrong in hospital around patient safety. Then trying to understand the response of the health service to that thing that went wrong, and trying to understand what happened, why it happened, how we can stop that happening again. And so health services should undertake an investigation when something goes wrong in hospital. So I'm thinking like a delayed diagnosis or a medication incident, or a patient deteriorates, but they're not detected and care's not escalated, that kind of thing. But we know those investigations are not necessarily fulfilling those needs because the same things keep happening again. So by definition, they're not fulfilling their goals. So our research is to look into why that is, and how we can improve.
And so I guess from what you're saying there, it kind of makes sense why you're here at the summit with RLDatix. We're talking a lot around, quality and control and what to do with data and all of that. But I'd love to hear from you, like what's brought you to this summit? And I understand you're up on a stage a bit later on today.
Yes. So really the research, I've been to a few of these summits. So there's very much a crossover between RLDatix's work in terms of incident management systems. So when something goes wrong in healthcare, like one of those incidents, it's generally reported through often one of those systems. Okay. So, and then there's a process of that incident being managed through the system. And if it's a serious incident, then an investigation will occur. So there's very much a link between, I suppose, the aims of what they want to do as an organisation, which is, have software that is accessible to people, is usable, all those things you need with software that it actually works, and that it fulfills its goals of managing incidents. And my side is then with the serious incidents around ensuring that process works really well. If you look into the RLDatix systems in the States, the investigation reports that are actually produced then get appended to those incident reports.
Right.
Okay. And the process then what happens to those recommendations and actions over time can also be appended into those into that system.
Yeah. Like I think about what you said earlier too, we're getting good visibility and things are progressing and innovation, everything, but incidents keep happening, issues still occur. So I guess, as I think about it too, there's no point having a really good, or there's only a certain value in having a really good system that can tell you with clarity what happened. That's one element, but I guess what do we do now? That's the kind of next thing. So that would be an interesting thing to unpack, I guess. Is that a realistic expectation that it's healthcare, things can go wrong? Like at what point is it, just things are going to happen? How much control do we have over these types of things?
So we asked that question about preventability. So it's a really good question to ask. So we do have very sick people in the system. And part of that, I suppose, triage process early on is to try and understand, well, how preventable is this incident? We have people dying in hospital all the time, obviously. And most of the time they're dying from natural causes, from their illness and disease. But there are times when the care that is delivered may have an impact on potentially disability, or in worst case scenarios, a death. That doesn't happen very often, but it does actually contribute to it. So it's very much a live question because we want to put most of our resources into where we can be most effective. And so, so we need to have we need to be asking those questions early to say, put our investigation resources into those incidents that are most preventable. So, you can use the example, let's say, of medication incidents. I was at presentation this morning, and there's an international problem where we have packaging, say for fluids, so you're giving intravenous fluids, and the packaging for glucose, sodium chloride, and potassium chloride pretty well looks the same. Right. So, and potassium chloride is quite a dangerous fluid. So, it is, that's a risk that busy healthcare workers need to confront, because that design of that medication packaging is not optimal. So, and if that happens, it's a entirely preventable thing that's gone wrong. Yeah. So what we're trying to do is come up with systems changes to try and change that packaging, standardize that packaging, and have alerts and make it really clear that it is actually this dangerous medication that's potassium. So have it stored in a different spot, and have those checks and balances as well.
One thing I think about within healthcare is that, if it was a static environment with no change, I guess we could get really, really good at it and really control the risks. Yeah. And on one hand, as we've heard about at the summit, continuing a rapid rate of innovation and change and new ideas and great things, which often are positioned as and intended to improve patient outcomes, improve efficiencies and safety and quality as well. But I guess by introducing new change and new technologies, it also can increase risks as well. Where do you sit on that balance of we need to try and control all the risks around technologies and perhaps, take a step back a little bit to make sure things are safe? Or do we is artificial intelligence going to save the world and make things much safer and more effective? It's kind of, I'm not sure what the right answer is, but I guess there's a bit of a balance.
Yeah, there is. And so one of my colleagues, Joanna Westbrook's, done some really nice evaluative work on electronic prescribing systems for medications. So prescribing medication, it's a complex business. You've often got frail people who are on lots of medications in hospitals, and over time, and this is, in the last decade or 15 years now, that we've converted from systems on paper to now electronic prescribing systems. And what Joanna's work has shown is they are safer. So there's less serious adverse events from prescribing medications in electronic systems, but they introduce new errors, different errors. Yep. So we do need to keep our eyes open. We do need to look at those business cases, but also be testing and evaluating those systems all the time. Yeah. One of the big things that I think we don't do as well as we can, and we often use the example of let's say infusion pumps, in intensive care units or surgical wards or medical wards, which are delivering continuous doses of medications to patients. We can think about that from a safety perspective when something goes wrong, but really early on, when health services are thinking about, we need some new infusion pumps, there's very well established processes to get clinicians involved in that procurement process and doing human factors testing of those systems by clinicians who are working with patients. And so you can have a process where you look at, what do we want this infusion pump to do? But there's also another set of questions around, what could possibly go wrong? So it's a different sort of assessment. Yeah. So, and what we're advocating is, and we've actually done this with, I've actually been involved in a process where we looked at electronic chemotherapy prescribing systems. We developed up some scenarios for prescribers of chemotherapy, which is a dangerous set of drugs, and the nurses administering that medications and the pharmacists dispensing that medication, and then we got them to test the various software systems that were in that process. So that was a really valuable process that you can go through. Yeah, so that's there's some of those ideas, but we need innovation.
Yes.
But we just need to do it carefully and in a considered way, and make sure we do put enough, maybe 10% of the resources into the risk side of things.
Yeah, we don't just want to trade off one set of problems for another. You know, that's good. And lastly, you'll be up on the stage shortly here at the summit, but what would you hope that attendees of this event take away from that for us to wrap up?
So I'm going to talk a little bit about our research, and we're still right in the middle of it, So, but we're starting to think about the best practice principles for what an investigation and a response to serious adverse events looks like from the health service level. So what health services should be doing, but also what the responsibilities of departments of health as well. So we need, again, using that medication example of the IV bags. There's sometimes health services are a little bit limited in what they can do.
Yeah.
So we really need the departments of health to be recognising those risks, and it's really an international effort actually, for them to take some responsibility for some of those risks and be talking to the manufacturers of that packaging to try and get some change. So I'm really trying to break up the responsibilities of the different actors in the system, because it's a complex response system, and how we can do it better. But at the moment, because we haven't completed our research, our thinking is very draft. So I'm actually hopefully want to just start a bit of a discussion and debate with people here and say, what do you think about these draft principles? And because we're going to do that formally, but we'll do that informally today.
Place to do it, yeah.
Yeah.